I would like to show you lecture about sagittal bite anomalies. Etiology, pathogenesis, symptoms, diagnosis, prevention and treatment. And let's remember about development of the head, face and oral cavity.
The facial
Once
features of the
again.
human embryo develop rapidly very early on in pregnancy, beginning around the fourth week after conception. Many of the structures of the face originate from a group of cells called cranial neural crest cells. These cells move in a distinct pattern from the neural tube located in the back of the embryo to create the various structures of the face. Aberrations in the formation or behavior of these cells are the main causes of abnormalities in the head and face. During the first 3 days of development, the fertilized ovum, or egg, is located in the fallopian tube. As it travels down the tube, it undergoes rapid divisions to form a cluster of cells called the morula. These cells then organize themselves to form the blastocyst, and by the end of week 5, the fully formed blastocyst comes into contact with the uterine wall for implantation. During the second week of development, the inside of the blastocyst, known as the embryoblast, becomes 2 layers, the hypoblast and the epiblast layers. Together, these layers form an oval-shaped disc-like structure. In the third week of development, a streak is created on the surface of the epiblast, during which time the cells of the epiblast detach and migrate. These migrating cells create 3 layers, the ectoderm, mesoderm, and endoderm layers, which go on to contribute cells to form all the tissues and organs in the human body. In the third to fourth weeks of development, a cord called the notochord is formed. This induces the cells in the overlying ectoderm to thicken, forming a region called the neural plate along the back of the embryo. The edges of the neural plate elevate to form the neural folds that eventually fuse to form the neural tube. During this process, neural crest cells are formed along the entire length of the tube at the tip of the folding neural folds. Neural crest cells formed from the head or cranial region are called cranial neural crest cells, or CNCCs. These cells multiply and soon start migrating over long distances in distinct paths from the back of the embryo towards the front of the embryo. Once they arrive at their target destinations in the facial regions, CNCCs further develop and mature and ultimately contribute to a substantial amount of the structures in the head and neck region, such as bones, cartilage, and nerves. Growth, migration, and subsequent differentiation of CNCCs are critically important for proper development of the normal structures of the facial region. Soon after the CNCCs reach their final destination, the facial structures begin to take shape externally. By the fourth week of development, the embryo is characterized by 5 facial swellings, the frontonasal prominence, and the paired maxillary and mandibular prominences. These structures are formed in part from the migration and proliferation of the CNCCs from different regions of the neural tube. In a 5-week-old embryo, the nasal placodes, which will go on to become the olfactory system, and the optic placodes, which will become the lenses of the eyes, will form. In addition, the maxillary and mandibular prominences enlarge and grow forward and towards the middle, eventually giving rise to the upper and lower jaws, respectively. In a 6-week-old embryo, the 2 mandibular prominences fuse to form the lower jaw. At this point, the outline of the mouth is visible. In the 7-week-old embryo, the maxillary prominences grow and fuse to form the border of the nostril and the upper lip. Merging of the maxillary and mandibular prominences forms the cheek and the corners of the mouth. The philtrum of the upper lip and palate are also created at this time. In this flurry of activity in the first 7 weeks after fertilization, the 5 facial prominences give rise to the formation of the forehead and sides of the face, middle and sides of the nose, the philtrum, the upper lip, the palate, and the lower jaw. By the 7th week of human embryonic development, most of the facial structures can be observed. In the next few months of development, the initial cartilaginous skeleton of the face is replaced by bone, and there is an overall increase in shape and size of the different structures of the face. From childhood to adulthood, the face continues to develop through further growth and remodeling.
And another animation about the development of the face. So, plan of this lecture. First chapter, classification of sagittal bite anomalies by different authors. And then second chapter, distal occlusion. And third one, mesial occlusion. I would like to mention you about cornerstones of medicine and of dentistry. About planes. As you know, there are three mutually perpendicular planes: sagittal, transversal or horizontal, and coronal or vertical plane. What does it mean? Sagittal plane, a comedian plane. It is an imaginary plane that passes longitudinally through the middle of the head and divides it into right and left halves, used to describe anterior-posterior relationship. Now let's talk about different classification of sagittal bite anomalies. As can you see, many authors developed their own classifications, and many other authors create their own classifications. But as for me, the most important and the most useful Angle Katz, Elena Markusyan and Betterman classifications. Classification by angle. Angle called distal bite, second class, and divided it pathology into two divisions. Division 1, existing gap in sagittal plane, and Division 2, no gap in sagittal plane. An opposite situation, opposite pathology, mesial bite, or class 3. Class 2, Division 1, existing gap in sagittal. Class 2, Division 2, no gap in sagittal. And mesial bite, third class by angle. Another author, Katz, created this same classification but called that pathology not classes but groups. Group second and group third. But in Katz's opinion, reasons of development of that pathology are protractors hypofunction or protractors overactivity. Elena Markusyan, Soviet orthodontist, created her own classification and called distal bite posterior bite and mesial bite anterior bite. But in her opinion, all this pathology can be without displacement of lower jaw, with displacement of lower jaw, and combined forms. But as for me, the most universal classification of sagittal bite anomalies was created by Bettelman, Soviet scientist. Bettelman He called it distal occlusion and divided it into 4 forms. First form, lower micrognathia. Second form, upper macrognathia. Third form, upper macrognathia and lower micrognathia. And fourth form, maxillary prognatism with narrowing in the lateral parts. And mesial occlusion, he divided into 3 forms. First, upper micrognathia. Second, lower macrognathia. And third form, upper micrognathia and lower macrognathia. Now I will show you it in schemes. There schematically shown cranium, upper jaw with dentures with teeth, and lower jaw with teeth. And they are shown normal physiological correlation between that parts. But according to Bettelman, distal occlusion of first form, lower micrognathia, is caused by distal position of lower jaw. Second form of distal occlusion, upper macrognathia, according to Bettelman, caused by mesial movement of upper jaw with teeth. And third form of distal occlusion, forward position of upper jaw and distal position of lower jaw. The same principles Bettelman used to classify mesial occlusion. First form, upper micrognathia, distal position of maxilla. Second form, lower macrognathia. And third form, combined, upper micrognathia and lower macrognathia. And really, this form of mesial occlusion is the most widespread. Let's see again. Normal occlusion, distal bite, distal correlation, and mesial bite, mesial correlation. And now let's talk about distal occlusion with standard scheme: etiology, pathogenesis, clinical manifestations, diagnosis, prevention and treatment of distal occlusion. Now about terms.
The upper front teeth extend beyond lower front teeth. Because they stick out, they can easily get hit, chipped, or even knocked out.
Overjet.
Biting into food can also be frustrating because the top and bottom teeth don't touch. Some patients will even experience speech difficulties, and the lips may not fully close over the teeth. This can make the mouth look top-heavy, especially from the side view. Overbite. The upper front teeth bite too far down over the lower front teeth. This can result in the lower front teeth biting into sensitive tissues on the roof of the mouth. Chewing can be difficult because the jaw cannot function normally. Also, the lips don't fit properly, which can make the mouth appear misshapen.
Please notice, overjet, it is a gap in horizontal direction, overbite in a vertical direction.
The upper front teeth extend beyond lower front teeth. Because they stick out, they can easily get hit, chipped, or even knocked out. Biting into food can also be frustrating because the top and bottom teeth don't touch. Some patients will even experience speech difficulties, and the lips may not fully close over the teeth. This can make the mouth look top-heavy, especially from the side view. Overbite. The upper front teeth bite too far down over the lower front teeth. This can result in the lower front teeth biting into sensitive tissues on the roof of the mouth. Chewing can be difficult because the jaw cannot function normally. Also, the lips don't fit properly, which can make the mouth appear misshapen.
Etiology. What reasons can cause development of distal bite pathology? At first, of course, heredity. It is a universal reason. Prenatal factors. Universal reason too. Like radiation, junk food, drinking, smoking of pregnant women, and obstetric intervention in childbirth. Interventions like manual forceps or a vacuum can damage lower jaw and cause bad growing in the future. Of course, the nature of feeding. Normal position of upper and lower jaw in newborn, called physiological distal bite, and then this position must be corrected and lower jaw must grow forward. It stimulates breastfeeding. Growing of lower jaw is impossible without breastfeeding. But artificial feeding, it is a risk factor for development of distal bite. Of course, the nature of food. Cooked food, soft food, doesn't give enough loading on masticatory muscles and on bones, and as a result can lead to weakness of muscles and not enough growing of bone. Very important reason, violation of nasal breathing or mouth breathing. Please look at this animation. They're very clear shown this effect.
The mouth breather typically has the lips open most of the time. This makes the facial development narrow and long. Like the reverse swallow, the tongue tip pushes forward generally between the teeth, which do not contact during swallowing. There are many variations of this, but the elements are the same. The mandible moves back. The tongue action prevents correct arch development. A narrow V-shaped upper arch with crowding is the result. Typically, a Class 2 Division 1 with open bite is created by the action of the tongue.
As can you see, they are shown distal correlation of teeth, distal correlation of first molars.
The backward movement of the mandible in swallowing compresses the TM joint, causing TMJ problems.
Moreover, can develop temporomandibular disorders.
The mouth breather typically has the lips open most of the time. This makes the facial development narrow and long. Like the reverse swallow, the tongue tip pushes forward generally between the teeth, which do not contact during swallowing. There are many variations of this, but the elements are the same. The mandible moves back. The tongue action prevents correct arch development. A narrow V-shaped upper arch with crowding is the result. Typically, a Class 2 Division 1 with open bite is created by the action of the tongue. The backward movement of the mandible in swallowing compresses the TM joint, causing TMJ problems.
Next reason, rickets and bad habits like some sucking on or different things sucking or nips sucking. So clinical manifestation. You remember that we need to evaluate facial signs of bite and intraoral signs. What facial features of distal bite? It can be extension of upper jaw, or like in this scheme, extension of upper jaw, or distal position of lower jaw, like here. You know, veneer or another famous person. So much famous persons have distal bite. And one facial feature more, height of the lower third of the face, as usual, is decreased. It is a real patient, and as can you see, lower third is smaller than middle third. This height is decreased. And intraoral features. Of course, molars and premolars are located on the second class, like here. Gap for sagittal in the frontal area in case of 2-1 class pathology. Class 2 Division 1. In a real patient. Gap for sagittal in the frontal area in case of 2-1 diagnosis. Biovertical we can observe deep bite and open bite. Deep bite or open bite. And by transversal, very often we can observe cross bite. Deep cross bite. What about diagnosis? Except of clinical examination, we can conduct clinical tests like Ashler-Bittner test, and of course, to establish type of pathology, skeletal, dental velar or combined, and degree of pathology, we need use cephalometric evaluation of cephalometric X-ray. And what about treatment? Treatment of pathology like distal bite depends on three things: the patient's age, clinical forms, and severity of disease. Let's talk about patient's age. As we know, dental age is divided into three bite periods: temporary bite period, mixed bite period, and permanent bite period. At the temporary bite period, treatment tactics will be headed into sanitation of the nasopharynx, rational feeding, myo-exercise, elimination bad habits. In one phrase, it called eliminate cause of disease, and only then we can have instrumental treatment. What can we do to eliminate reasons of this pathology in temporary bite period? Of course, at first we need to treat adenoids to normalize nasal breathing. As you know, the spatial term adenoid face, it is long face with open mouth. Long face with open mouth. Another reason can be nasal septum deviation. And to eliminate this reason, we can recommend for patients to have surgical intervention to correct deviated nasal septum and normalize nasal breathing. Nasal polyps. You can see that one half of nasal cavity is fully obstructed by nasal polyps. And of course, this patient cannot have normal nasal breathing. Or chronic rhinitis. As usual, it is allergic rhinitis. We need to recommend for these patients to visit otorhinolaryngologist and to treat that pathology. and of course sanitation of nasopharynx. But another bad habits, like thumb sucking, we must eliminate ourselves. How can we do it? There are many devices to eliminate this bad habit. For example, nipped hand stopper. What does it mean? The nipped hand stopper, also known as the thumb stopper, allows for total arm mobility until the elbow bends to about 100 degrees. Just past the mid-bending point, the Velcro attached stopper acts as a brake between the fore and upper arm. On the inside, underneath the stopper is a soft cushion so that the stopper does not cause any pain to the child but does apply firm pressure. In this scheme is shown principle of action of the device. Another way using very famous plug called Mavala stop. Mavala stop designed for children aged 3 and up. This clear enamel is put over the thumb or nails to prevent sucking or biting thanks to its bitter, yet harmless taste. For this technique to be effective, it needs to be reapplied every 2 days, with the original layer removed prior with nail polish remover. The reason it's not recommended for kids under 3 years old is because their taste buds aren't developed properly yet, and they might get used to the taste. And as a result, we can get opposite effect. We can recommend for parents thumb guard. This device, this plastic shield worn over the child's thumb and held in place with a bracelet, is designed to stop the suck motion from happening when they pop their thumb in their mouth, and therefore takes away the pleasure from the activity. Or we can recommend thumb glove. There are lots of various thumb gloves. It simply straps onto child's hand to help remind them not to suck their thumb. But we can propose for patients, maybe not for patients, but for parents of the child, intraoral unremovable appliances. And first of them, called the hair rake appliance. The hair rake appliance features short prongs or spikes that poke or irritate the fleshy part of the thumb when inserted into the mouth. Rake appliances punish the patient each time they try to suck their thumb. This is called punitive reinforcement. The spikes poke the thumb, causing discomfort or pain where the thumb is inserted.
This is Paul from Orthodontic Laboratories.
And
Many doctors request us to construct an appliance called a hay rake, a thumb-sucking reminder to remind the patient to eliminate the harmful habit of sucking a thumb. This does not prevent the thumb from going into the mouth. It takes away the enjoyment of having the thumb in the roof of the mouth. Traditionally, what many doctors find, after a month or 2 months, if the patient has not eliminated the habit, these wires that protrude anteriorly, they will bend downwards in a 90-degree bend to act as more of a deterrent. After about 3 or 4 months, if the patient still hasn't eliminated the habit, many doctors will remove the appliance because it has become commonplace, and then may reinsert it about a month later to act as a behavior modification, because the patient hasn't been used to wearing it. Once you put it in, it's a back to the drawing board, if I may say, in putting the habit appliance in. Traditionally, doctors will say it's the child, the parent, and the doctor, unison, trying to eliminate this habit. Traditionally, doctors will say it's the child, hay rake appliance to be either banded on the primaries or the permanent dentition. All for more done. Hay rake appliance can be either banded on the primaries or the permanent dentition. All for more done. Thank you.
Do you understand, yes, that this appliance you can wear into primary or permanent teeth? Or another kind of unremovable intraoral appliance called the thumb crimp. The thumb crimp features a cage or a fence that rests just below the roof of the mouth. Thumb crimp habit appliance works by preventing the pressure and sucking sensation at the roof of the mouth. With the thumb crimp, sucking the thumb provides no stimulus, is deemed useless, and the habit is broken with consistent wear. And another very interesting appliance called the bluegrass appliance. The main feature of a bluegrass appliance is a roller. The roller is placed towards the front half of the roof of the mouth. Patients turn the roller with their tongue instead of sucking a thumb. This gives the child an alternative to the sucking habit and is effective an anti-thumb sucking device. Because this anti-thumb sucking device is based around positive reinforcement and is less aggressive, it can be used in early mixed dentition or with kids as young as 6 or 7. And only then we can use instrumental treatment. Only after elimination of bad habits we can use some devices to correct distal bite. And at the period of temporary bite we can use only removable devices, and these removable devices can be functional acting or functional gating. First of all, we can use LM activator, a removable function acting device.
LM activator is a very simple and interesting orthodontic appliance. This kind of appliance is able to control the growth. When I saw the results of LM Activator, I was surprised. Occlusion after treatment with this appliance is very good. LM Activator in a way helps the growth of the jaws. It will have expanding effect on upper and lower jaw if there is crowding, if there is need of extra space, and it will also enhance the growth of the mandible. We can find the right direction of the groove, so we can control in a three-dimensional way the occlusion and to have a great result in a short time with a very simple way. I recommend my colleagues to try LM Activator and see the results themselves. We can find the right direction of the groove, so we can control in a three-dimensional way the occlusion and to have a great result in a short time with a very simple way. I recommend my colleagues to try LM Activator and see the results themselves.
And short animation about this device, LM Activator. We need ask patient put it into dental rows and close teeth. To get a good effect, patient must have upper and lower teeth closed. Mixed bite period. Principles of treatment are the same. Firstly, we need to eliminate cause of disease, and only then we can use instrumental treatment. What kind of appliances we can use in this period? Of course, removable, functional guiding, but unremovable too, mechanical acting device.
Over time, thumb sucking can have a dramatic impact on the alignment of teeth.
Over time, thumb sucking can have
a thumb habit appliance can help break this habit.
A thumb habit appliance can help break this
The
habit.
appliance makes it impossible to create suction, which is where the feeling of satisfaction comes from. Once the habit is broken, the teeth will start to return to their natural position.
Once the habit is broken, the teeth will start to return to their natural position.
Another reason, bad habit, like laying tongue between teeth. And we can put tongue shield. We can manufacture tongue shield. Or another kind of device, as was shown earlier in the upper jaw. Please notice there are shown distal correlation between upper and lower teeth. Lower first molar is positioned distally from upper first molar. We can use a removable appliance called twin block. Why twin block? Because this appliance have two parts, in upper and in a lower jaw, and these two parts are working only together. And we can insert a special screw for expansion of upper dental roof. And at the end we can use braces to correct some rotations. Twin block. And second form of distal occlusion, backward. And we can use unremovable appliance called distalizator. It is mechanical acting, unremovable appliance. And with that springs, buccal teeth will move distally. And as a result, we can establish normal correlation between upper and lower teeth. And permanent bite period. Please remember that removable appliances are not effective in permanent bite period, and effective treatment can be only with unremovable fixed mechanical acting devices. The elder device, Herbst appliance. Please look at animation about using Herbst appliance. Distal correlation between upper and lower teeth. Ignore. We can use partial crowns or maybe molar bands. This part has length enough to move lower jaw forward. And of course, to get the best results, we need to use brackets at the end, sorry, braces. As can you see, profile is changed and improved. similar appliance but from 3M company called Flex. As for me, the best additional appliance to treat distal bite in adolescents and adult. Sabach Universal Spring or SUS appliance. Please look at this video from manufacturer, from Dental company. And another similar device, but
the following is a demonstration of the forces fatigue-resistant device, showing installation, reactivation, and removal using the Forces Easy module. The following is a demonstration of the Forces fatigue-resistant device, showing installation, reactivation, and removal using the Forces Easy. There are 4 general clinical requirements for the Forces fatigue-resistant device. First, use either a 17 by 25 stainless steel arch wire or a 19 by 25 stainless steel arch wire, depending on your particular slot size. Second, all brackets except the lower cuspid brackets may be ligated with either stainless steel or elastomeric. The lower cuspid brackets need to be ligated with stainless steel ligatures. This will prevent unwanted rotation of the lower cuspids. Third, the lower arch wire should be securely cinched to control anchorage and mesial flaring of the lower arch. Fourth, the Forces Easy module requires the use of a buckle tube with a buccally offset occlusal headgear tube on the upper first molars. One option to avoid contact with the cuspid bracket is to place a stop, such as a Gurin lock, distal of the canine. Another option to increase anchorage on the lower arch and prevent lower interior flaring is to lace the entire lower arch and increase labial root torque on lower anteriors. Installation. Holding the mesial portion of the Easy module body with Weingart utility pliers, insert the Easy module clip into the headgear tube, from mesial to distal, until it clicks into place. Installation. Holding the mesial portion of the Easy module body with Weingart utility pliers, the correct pushrod size for the patient must be used. To measure the correct pushrod size, with the jaw closed, place the distal end of the measuring device behind the headgear tube and the mesial end of the gauge just distal of the lower cuspid bracket. The appropriate size pushrod is indicated. Note that the direct pushrods are in a left and right configuration and should be measured separately. After selecting the correct pushrod, place the distal end of the pushrod into the opening on the mesial end of the spring assembly, then place the mesial end of the pushrod onto the arch wire distal to the cuspid bracket. And should be measured separately. As a final check for correct pushrod sizing, with the jaw closed, make sure that the distal end of the pushrod does not extend distally from the spring assembly and that the spring is not fully compressed, with approximately 1 millimeter of activation remaining. As a final check for the spring assembly length after the installation should be 20 to 22 millimeters in length. If the pushrod protrudes distal of the spring module in centric occlusion, it's too long. To secure the pushrod onto the arch wire, simply close the mesial loop over the arch wire. Check to be sure that the spring operates freely and is not in occlusion. Repeat the installation on the opposite side. To secure the pushrod onto the arch wire, simply close the mesial loop over the arch wire. To reactivate the spring assembly, use the split crimps provided in the Forces fatigue-resistant device kit. Compress the spring so that the pushrod is exposed, and place the split crimp distal to the welded stop on the pushrod. Secure the crimp onto the pushrod. This will provide 2 millimeters of activation. If greater activation is required, more than one crimp, we recommend replacement of the pushrod with a longer pushrod. Secure the crimp onto the pushrod. Removal. First, with the patient's mouth open wide, compress the spring and remove the spring assembly from the pushrod. Then, holding the distal portion of the Easy module clip with Weingart utility pliers, pull the Easy module in an occlusal mesial direction and remove it from the headgear tube. This will provide 2 millimeters of activation. Pushrod removal. Grasp the distal end of the pushrod with your fingers, holding the mesial loop in place with your Weingart plier. Bend the pushrod to open the mesial loop and remove it from the arch wire.
First, with the patient's mouth open wide, compress the spring and remove the spring assembly.
This completes this instruction on installation, reactivation, and removal of the Forces fatigue-resistant device Easy Module.
Pull the Easy Module in an occlusal mesial direction and remove it from the headgear tube. Push rod removal. Grasp the distal end of the push rod with your fingers, holding the mesial loop in place with your Weingart plier. Bend the push rod to open the mesial loop and remove it from the arch wire.
Except of appliances of mechanical action. If patient will have high severity of this pathology, we can propose orthognathic surgery.
Two malocclusion occurs when one jaw or both jaws grow inappropriately and cause an overbite. This is a very common condition that can generally be treated with orthodontics. However, sometimes the jaw protrusion is so great that it requires surgery as well as orthodontics. The surgeon segments and repositions the jaw or jaw segments to correct for the overbite, and then secures them with special screws and plates and allows
An opposite pathology, mesial occlusion.
Lower front teeth extend beyond the upper front teeth. Once again, the teeth don't touch, so biting into food is difficult or
Let's
impossible.
mention about
Speech difficulties can also result. The chin sticks out beyond the upper lip, again causing an unbalanced profile view. Or impossible. Speech difficulties can also result. The chin sticks out beyond the upper lip, again causing an unbalanced profile view.
What about etiology? At the first place, the heredity, then prenatal factors and others. I hope you know these persons. The European monarch dynasty Habsburgs. As can you see, all members of this dynasty have mesial. What about clinics? The same scheme. Facial features of lower jaw. Increasing the height of the lower third of the face. Like here. And intraoral features, closing molars and canines by third class, the ratio of front and narrow upper jaw, as usual the lateral. Diagnosis, the same way. Clinical tests, Ashler-Bittner test and cephalometric analysis to define type of pathology. This pathology can be skeletal, dental-alveolar and combined, and degree of pathology or severe pathology. And treatment we will conduct in the same scheme. Treatment depends on the patient's age, clinical forms, and severity of patient's age, temporary bite period. The same scheme. At first, we need to eliminate cause of disease, and only then we can use instrumental treatment. We can use the same Nipit hand stopper to eliminate bad habit like sucking of point finger. Sucking of thumb can cause distal bite, but sucking of another fingers can provoke development of mesial bite. Or we can use Mavala stop too. And only then, after elimination reasons of this, we can use instrumental treatment. Which kind of appliances we can use? We can use removable appliances, functional acting and functional guiding. Functional acting, well known for us, LN activator, and we can use extraoral appliance called chin cup. In mixed bite period, what we need to do? The same way, sanitation of the nasopharynx, rational feeding, exercise, elimination of bad habits, and only then instrumental treatment. The same nipid hand stopper in mixed bite period, the same Mavala. But differences will be in choosing of orthodontic appliances. In mixed bite period we can use removable but fixed orthodontic appliances too. And not only functional acting and functional guiding, but mechanical acting and intraoral and extraoral. The most effective removable orthodontic appliance functional acting is Frankel function regulator. For treatment mesial bite, we need to use Frankel function regulator of third type. As you know, this kind of removable orthodontic appliance can be first type, second type and third type. For treatment mesial bite pathology, we can use third type Frankel function regulator. Once again, it is very effective, but very awful orthodontic appliance. We can use reverse bionator too. Standard bionator is using for treatment of distal bite pathology, but we can ask dental laboratory to manufacture for us reverse bionator for mesial bite treatment. And we can use LM activator too in mixed bite period. And of course, we can use chin cup in mixed bite period. But at the age of permanent occlusion, only appliances of mechanical action are effective. And of course, orthodontic surgery and additional treatment. What appliances of mechanical action we can use in permanent bite period to treat mesial bite? We can use Meow methodics, multi-loop, edgewise, arch wire methodics to correct mesial bite. This methodics is very effective, but very difficult for doctor and extremely difficult for patient. or we can propose for our patients some surgical interventions, like orthodontic surgery.
A misalignment of the jaw that positions the upper teeth behind the lower teeth may require a corrective jaw procedure known as a Lefort 1 advancement to straighten or realign the upper jaw. One of the most commonly performed corrective jaw surgeries, the Lefort 1 advancement, is used to bring the middle of the face forward. The oral surgeon surgically separates the maxilla or upper jaw from the skull and moves it into the correct position. The repositioned jaw is then held in place with screws until the jaw heals, and the incision is
But as usual, this kind of orthodontic surgery is double jaw, not only upper jaw but lower jaw too.
A Class 3 malocclusion occurs when one jaw or both jaws grow inappropriately and cause an underbite. When the underbite is caused by the positions of the jaw rather than the position of the teeth, orthodontics alone cannot correct this problem. An operation is required to either shorten an overgrowth of the lower jaw or lengthen a growth deficiency of the upper jaw in order to align the bite properly. Once the jaws are moved into the proper position, they are secured with special screws and plates and allowed to heal.
There were shown different kinds of surgical interventions in upper jaw or in a lower jaw. But I would like to tell you again that, to repeat you, that as usual, for these patients, both jaw operation is. Thank you, doctors. I'm finished. Have a nice day.